I guess we are live in YouTube. So I'm opening with you. Good evening, everyone. Welcome to the EHS Journal Club tonight. Andy Beaux and I manage the session tonight. This month's article is European Hernia Society Guidelines on Management of Rectus Diastasis. The article was published in BGS at the beginning of this month. So esteemed authors of the paper are with us, and thank you for joining us all. This live meeting scheduled for the last 1 hour, so we want to keep the time tight. First, corresponding author Pilar Hernández will make a brief presentation of the paper, and then we will ask the questions. This meeting will also be broadcasted live on our YouTube account, I think so. We will also share the questions and contributions from there. So, Pilar.
Yeah. Wait a minute.
The screen.
Hakan, is it true we have lots of difficult questions to ask?
Yeah, exactly.
Glad to hear it.
Excuse me, I want to share the screen. Can you see my screen?
Yes, we can.
Yes.
We can see it and hear you.
Yeah. Thank you, Hakan and Andrew, for the opportunity to discuss our paper in this scenario. As there is a lack of consensus in the literature on definition, diagnosis, and therapeutic management of rectus diastasis, the EHS decided to develop this guideline. And this is our team. Oh, excuse me. This is our team from all over Europe, including the United Kingdom. This is us. And after the decision of the EHS, we met one time, and 90 questions were formulated and approved. And after the literature search, with no limits on date of languages, we create our first approach to the guidelines.
Kan du se om jag kan få in min bild här?
Excuse me?
Mm.
Sorry, we've got Agneta just chipping in, but keep going, Pilar.
Okay. Grading of recommendations, assessment, development, and evaluation was used. So the quality of the evidence was rated as high, moderate, low, or very low. And based on this, a statement and recommendation were proposed. The recommendations were classified as strong or weak, or can be updated after the consensus of the group, even if the level of the evidence is low. The 90 questions cover all over the things that we want to know. Definition, diagnosis, classification, symptoms, etc. But we are surgeons, as we are, the most interesting questions for us would be about the surgical treatment, I think. And I focus the discussion of our paper on these two questions. First, what are the surgical treatment options for patients with rectus diastasis without concomitant hernias? After the literature search, two main options for the surgical management for these patients were identified: linear valve application without mesh and with mesh. In the first option, as you can see, we found 3 randomized controlled trials and 10 observational studies with different approaches, open or laparoscopic, different type of sutures, absorbable, non-absorbable, variable sutures, and different suturing technique, 1 or 2 layers, running or interrupted. The number of patients was small in the majority of the studies, and the follow-up varied between 6 and 81 months. The other option of treatment was linear valve application with mesh reinforcement. The approach can be open or laparoscopic too. The type of suture used for application varied as in the other line, and the mesh can be placed on live, retromuscular, or intra-abdominal even. The number of patients varies between 10 and 184, and the follow-up varies to between 12 months and 48 months. and only 5 studies reported about functional results. The data presented are mostly of low quality and heterogeneous. And why, for this reason, open implication with long-term absorbable or non-absorbable sutures in 1 or 2 layers appears to provide a robust repair with low incidence of recurrence. It's problematic to say something about the use of mesh, of type, or position, and it's challenging too to make an argument on the role of a laparoscopic approach. And so the recommendation is, if surgery is performed, the technique used should result for a shared decision-making process between the patient and surgeon. Linear alba application is suggested in patients without concomitant hernia. No recommendation on the type of suture or suturing technique can be made. The quality of the evidence is low, and the strength of the evidence, and the strength of the evidence is weak. We would like to emphasize that the guideline groups strongly believe that the chosen technique should involve shared decision-making with the patient, and the table in the article summarizes the data in order to aid surgeons in this process. We proceed to the next key question, and you can see there are 100 options different to treat to make surgical treatment with patients with rectus diastasis and concomitant hernias. For example, as you can see here, one approach is endoscopic subcutaneous dissection with plication and online mesh. Different names: REPA, SCOLA, LR, MILAR. Other endoscopic dissection and plication and retromuscular mesh. So on, a number of techniques: EMILOS, TESAR, THT. In the other hand, open dissection with online mesh and or not abdominoplasty, and open dissection, retromuscular mesh, and or not abdominoplasty. With this variety, we can summarize the studies in this: endoscopic subcutaneous application and online mesh, the most reported techniques in 5 studies; open dissection with sublime mesh, 4 studies; endoscopic subcutaneous applications with sublime mesh, 4 studies 2; and open approach with online mesh, 2 studies. All the studies are observational. The type of suture, suturing technique, and type of mesh are variable, like in the other patients. And the recurrence rate is between 0 and 6%. Follow-up varies between 5 and 24 months, and only 2 studies reported on functional results. The studies are, one more time, are heterogeneous and of low quality. And in conclusion, in line with the recommendation of the AHS guidelines of treatment of umbilical and epigastric hernias, a mesh-based repair is suggested to repair rectus diastasis with concomitant midline hernias. Application of the linea alba may be sufficient to repair a diastasis associated with a small hernias less than 1 centimeter. Minimally invasive approaches are in their infancy, and the further studies in this area are needed. The variety and heterogeneity of techniques used, the small number of patients of each study, the absence of comparative studies, and the low quality of the evidence obtained prevent elaboration of any recommendation regarding the best approach or the type and position of mesh. The recommendation is that a mesh-based repair is suggested for patients with rectus diastasis and midline hernias. Application of the linea alba may be sufficient to repair a diastasis with the smallest hernias. The quality of the evidence is low, and the strength of the recommendation is weak. And I think it's enough for beginning the discussion. Hakan and Andrew?
Thanks very much, Pilar. Yes, so we lost Hakan. Hakan, are we ready to go to the questions?
Yeah, I'm sharing my screen and bringing this questions to the screen. Yeah, this is the paper. So this is the first question. Andrew, can you ask, please?
So our first question, in the guidelines, diastasis recti is defined as a linea alba width over 2 centimeters. Other studies suggest over 3 centimeters, and indeed a recent paper by a group from Switzerland have suggested that 3.4 centimeters should be the minimum before you consider diastasis. Can you explain to us the reason for the 2 centimeters?
Perhaps Nadia is the person appropriate to do that.
Yeah, this is very difficult, and we discussed a lot where to set the limit. But this was based on multiple studies on women that had not given birth and women that had given birth, where the linea alba width was measured after pregnancies and also before pregnancies. And that's why we put the cutoff at 2 centimeters, which was also the cutoff used by Wolfgang Reinpold's definition, and also by the previous definitions by Nienhuijs and Beaux. And yeah, that was why we chose 2 centimeters.
Are we then pathologizing a large number of people then? I can understand women postpartum, and a lot of the studies perhaps weren't particularly long follow-up, but women who haven't had children and men, are we giving them a disease they don't have?
Yeah, but what we also discussed is whether the diastasis itself, it's a definition on when there is a diastasis, but does that mean you have any symptoms from the diastasis? That is unknown, and it's also unknown whether you have a diastasis of 4 centimeters. Do you have more symptoms than one having a diastasis of 2, or even the ones having one at 6 centimeters? But these studies we referred to were mainly on women, and there is a new study by Ruth Kaufman, actually, from measuring CT scans, which was published very recently. So actually it was after our guideline. And it says that it should be 3 centimeters by measuring, I think, 200 CT scans. She proposed a limit of 3 centimeters. Yeah.
I think they actually suggested 3.4 centimeters, 34 millimeters, in 329 patients who had CT scans for appendicitis or kidney stones. That's obviously a degree of bias as is, because maybe patients with appendicitis or kidney stones have a higher rate or indeed a lower rate of diastasis. So obviously there is some selection bias in there, but it's an interesting concept. Do any of the other panel members wish to support Nadia in the 2 centimeters?
Agneta.
I think that is a very difficult task to put a centimeter, really 2 or 3 or 3.5 and so on, because it's a matter of if you regard it as a problem as a patient. Because a lot of if you go to men, they would have quite wider diastasis and they won't notice anything unless they go in swimming pants and be on the beach or whatever. But when it has any medical consequences, then we probably should stay at accepting a bit wider range than 2 centimeters, 2 or 3. I think that would.
And for clarity relating to the width, does it matter where you measure it? Or I don't see a stipulation in the guideline that it's 3 centimeters above the umbilicus, or it's halfway between the umbilicus and the xiphisternum, or indeed if it matters if it's below the umbilicus, or if these measurements, it doesn't really matter where you measure it, they still hold true.
Yeah, it does matter where you measure it, because it is wider. For most people, it's wider above the umbilicus. And I think it is in the diagnostics key question, we said it should be measured 3 centimeters above the umbilicus.
Yes, that's defined there.
But But I think it's very important to highlight that whether you have a diastasis or not, with which we defined as a width above 2 centimeters, that doesn't mean whether you should get a surgery or not. It's not the width alone that is important, it's the symptoms that the patients have.
Sure. No, I appreciate that.
Yes. Can I ask?
Manuel, yes?
Yeah. For me, it's important the last word from Nadia, because we can discuss about centimeters, but how we can connect this measure with the clinical complaints of the patient. For me, that's the question. The most important question is the diastasis of 3 centimeters the responsible for the clinical complaints is per se, or is an alteration of the abdominal wall? I don't know. For me, the most difficult task here is to connect the classifications about rectus, about distance in the linea alba with the clinical complaints. I don't know what the rest.
I think we'll come back to that, Manuel, later. That's certainly a question that I have about both symptoms ascribed to the divarication and then outcomes, because I think you had some interesting data on outcomes. And what do you think about moving on to the next question, Hakan?
Yeah. Second question, as you see, the proposed classification does not include the symptoms of diastasis recti, although they appear vital regarding the decision to operate. Repair of diastasis recti, is it not quality of life surgery?
Manuel, you sort of brought this up. Would you like to come back to this?
Yes, for me, this is, again, the most important aspect, whether the symptoms of diastasis recti is for the diastasis of the linea alba, or is for alteration of the complete abdominal wall, or the symptoms comes for problems in the back of the patient. I am not sure. Sometimes when I operate on this type of patient, I don't know what will be the results at the end, because in my opinion, important percentage of these patients, they are only cosmetic complaints regarding the diastasis recti.
And it'd be fair to say there's not much cosmetic outcome data in the literature. Is that true?
Yeah, sure.
So we're doing an operation for cosmesis, but we haven't really measured it, which is obviously an interesting concept. I guess, Hakan, the European Hernia Society classification of inguinal hernias doesn't mention symptoms either. It's just based around size, because I guess size and presence or absence is dichotomous. It's perhaps a little easier to make a definition where it's easy to get the endpoints, whereas adding in symptoms, as Manuel said, are the symptoms due to diastasis or are they unrelated? I just have looked again at the table, and I guess in future, when we reproduce the table, we should say for D is interrectus distance 3 centimeters above the umbilicus, because that would be what many people will turn to, but that's a minor point. Any other comments from the panel around this question?
Nope.
No.
Good. So let's move on. Next one.
So question 3, if diastasis recti needs repair, when to mesh and where to mesh, which to lane,
I don't know. I don't know. It's impossible to know, because there are so many different studies with low quality, low number of patients. The mesh is put online, sublayer, retromuscular, intra-abdominal, laparoscopic, open approach. It's impossible to compare one study with another. And in this sense, we can't say anything and recommend anything. We think that the best decision is the best approach is the shared decision making with the patient. You offer to the patient the technique that you should that give the better results in your hands, and the patient need to decide if she or he want to embark in this project or not. Perhaps Manuel can help me.
So from your reading, did you get a feeling that there was any values, whether that's recurrence or whether it was symptom control, were better with mesh? Or is this one of the rare abdominal wall conditions where mesh is not really of much benefit?
It's not clear. It's not clear. There are a lot of studies that with absolutely only application, the results are good with 0% of recurrences at 5 years of follow-up. And the majority of surgeons and the majority of the studies only use mesh when there is a hernia associated with a rectus diastasis.
I suppose a key question here is we're talking about the patient-doctor interaction. So the question I have then is a sort of an auxiliary question is, did you involve patients in the guideline? Were they part of the group that were telling us the symptoms or the outcomes that were important?
It's impossible to involve patients in the guideline groups. We tried to do it in the past, but it's impossible, absolutely. And we want to include 2 physiotherapists, but we couldn't do it.
Pilar, impossible or difficult? We know that there are many guideline
difficult
groups
and impossible, even in COVID times.
I've got Nicola Dams, who has been a patient, an ex-nurse, and Rods, I'm not sure I can repeat all that she has written, but she's a very strong advocate of patients. And indeed, does grade methodology not suggest that patients should be involved? Manuel?
Yes. Grade methodology include patients and stakeholders need to be involved to evaluate and make a guideline with a grade methodology. But in cases that is impossible to do it, I think our experience with the patients is the same. Manuel perhaps can help me again.
So maybe that's something we need to look at in the future. We may need to recruit Nicola to help us, but we would need, I think, to add validity to these guidelines, we would need a patient focus group. Now, obviously, it's kind of difficult and they rely on us choosing patients or to make sure that they're patients with rectus diastasis, both fixed and unfixed, rather than just patients with a hernia. But I think this is an important step for the future. That we're operating on someone, we're not really sure if we're doing a patient's much good, and they haven't really told us what they want as their outcome. We see a bulge and we think, yeah, we can make that bulge better. Maybe I'm being unkind because I've certainly operated on a lot of these myself, but I think patients are the key and we may need to.
Sure. If I may, Andrew, I think you're absolutely right. On the other hand, I think one of the reasons why it was not impossible, but very difficult to include that is that also the way that we treat our patients is based on personal experience more than on any literature in general. And so I think within the group, we said that if we involve this statement on a patient's interaction with the surgeon, it's the best how we can more or less reflect the importance of a patient's opinion, which of course is very individual as well. And we were also, as I remember correctly, we were not that sure that if we have a patient representative per se, that it would reflect the opinion of a complete patient group as such. And so I think these different aspects, although, again, we agree completely with you, I think as a group to involve patients, it was in that way that we interpreted the way that we put the guidelines on paper.
Yeah, I think you're right, Frederik. One patient, a sort of token patient, or even two, often in that environment, they're maybe not that keen to speak up or be quite so vocal. Some will be, some won't be. But we do need to perhaps look at how the EHS can produce a patient bank in a sense that we can rely on as we go through our guidelines with different hernia types to get involved. And I guess that would be a separate focus group, which often needs management too. Doctors themselves are not always the best at getting information out of patients, but there are people that help us. Yeah.
Agree.
So we're not quite sure when to mesh or what mesh and where, but there's some suggestion that maybe mesh is slightly more reliable. And did you get the feeling that mesh would be more reliable as you went from D1 to D2 to D3, or was that more of an idiosyncratic thing, or was the data not in the literature?
There is no data in the literature about this.
So we need
studies included patients with rectus diastasis over 2 centimeters to 6 centimeters, but no differences between the lowest margin of the higher.
Yeah. So we need a registry then. If there's not many good studies,
we need a registry.
We need a registry of rectus diastasis. Okay, that's noted. I'll feed that back to Dr. East, the EHS Secretary for Quality, and tell her that I want a registry by tomorrow.
Maybe just
one comment on how the question is put. If diastasis recti needs repair, I think that way of putting the question is a bit biased or wrong, because if it's needed or not needed, it's maybe not the right way to put it. It's would it interfere with life quality, or would it proceed to better health or whatever? But what need is
yes,
more.
I think you're right. Maybe merits repair would be better, but I still think, Agneta, you're trying to wheedle out to the answer by picking on our question. I'm very disappointed in you, but we'll try harder to prepare our questions more carefully next time.
Yeah, that's just a late reflection.
Frederik, I interrupted you.
No problem. I just think it's interesting to mention that indeed, and it's a pity that David cannot be online with us, but I think the interaction with the plastic surgeon that we involved from the UK as well was interesting in the way that the tissue repair in his mind, and probably representing more of the plastic surgeons than of hernia surgeons, was actually focused already in the beginning much more towards tissue repair and not to use a mesh in most of his cases. And so we discussed a lot about, of course, we could not rely on the literature in that very much, but I think there was quite a clear, let's say, difference between his point of view as a plastic surgeon versus most of our view using mesh all the time. And although we did not come to a consensus when to use or when not to use mesh, I think this is again something that we need to find out in future or registries or future studies.
And I also, if I can comment
Nadia?
on that, I also think that it is important to say that a diastasis is not a hernia; it's a different pathology. We don't know why it happens, but it is the linea alba that gets thin and of low quality, and it's not a defect in the same way as a hernia. So
that's true, Nadia. I often think that when we measure the interrectal distance, but yet when I get a patient to do a sit-up, the bulge seems to be very much bigger, almost as if it's not just the linea alba that's bulging, but is there some rectus muscle dysfunction which also contributes to the bulge? Because I see some pretty massive diastasis, and then when you operate on them, I'm not impressed that the muscles are very far apart. Now, obviously, you're operating on them relaxed, but is it more than just linea alba?
Yeah, I think it is. And we had a very interesting talk at the Hernia 2021 by a physiotherapist who actually showed us how he could make the patient contract the transversus abdominis muscle and thereby decrease the bulge coming. So I think it is also some dysfunctioning in activation of the abdominal wall in some way.
We didn't really discuss it, Nadia, but there's not a lot of evidence around physiotherapy either. But is that something that we should stress first, that surgery follows after intense physio? And is that obligatory as part of rehabilitation?
Mm-hmm.
Yeah. Yeah, we suggested that. We suggested physiotherapy before repair, and we couldn't find a lot of evidence supporting that. But I think most of us in the group, apart from the plastic surgeon, agreed that we would always, we would never operate on a patient that hadn't tried physiotherapy in some way first. The problem is, again, then which kind of physiotherapy should you do? Because there are many, there is a religion in this diastasis world, whether you may or may not use the rectus muscles, or you should only use the transversus abdominis muscle. And even in Denmark, there are groups saying that they shouldn't use the abdominal wall at all. They should just wear a binder and relax, and then the connective tissue in some way should just grow together. So there is a lot of religion concerning physiotherapy as well.
Mm-hmm.
Yeah. Manuel, I think you wanted to say something.
Yeah, I would like to do a comment, because if we consider that diastasis recti is not a hernia and it's an abdominal wall function alteration, maybe we should insist into physiotherapy, because if we insist on the surgical treatment, maybe we are doing over-treatment of this process. We are over-treating these patients. We are doing meshes, prostheses. We are doing complex operations, component separation, and so on. Because if we have a diastasis recti of 8 centimeters in transverse diameter, we are over-treating these patients, doing surgery. Maybe we should insist in physiotherapy. We don't know a lot of things related with diastasis recti. We don't know the connection of the diastasis with the clinical complaints, as I said previously. We don't know how to measure the outcomes. We don't know which is the best surgical approach. Maybe we are over-treating this type of patients.
That's possible. Let's move on to the next question, Hakan.
So we've run a poll on our Twitter account, and you see the results. The question is: a diastasis recti with concomitant primary midline hernia, should hernia repair include the diastasis?
It's a good question.
A mixed outcome, slightly more in favor of both. We didn't discriminate between the etiology, male or female, or we didn't make any comment about fitness. But what do the panel think? Pilar, would you repair both most times?
We discuss a lot in our team about this question. There are so many papers in the literature that only repair the umbilical hernia or the epigastric hernia and don't touch the diastasis, and the contrary, papers that repair both. But the results are not clear, and there are not comparable groups. It's impossible to set a recommendation or make a statement to recommend in one sense, in one way or another. Impossible, because the evidence is absolutely scarce.
Let's put the question a different way. You might see a gentleman, for example, with a diastasis who you would encourage not to have a repair, but then they come back a year or two later with an umbilical hernia. Would you then say, well, the balance of risks are different, there's a hernia, let's do both, or would you still just do one?
I answer only on my personal experience, no by the evidence. In my personal experience, I repair both, probably. But only in my personal experience, no with the evidence. With the evidence, we can't say this.
The rest of the panel, would they go with Pilar's view, or do they hold any strong feelings in a different way?
Andrew, it is said that if we don't repair the diastasis, the hernia recurrences increase. But I am not sure about that, because the data about this comes from some observational studies with indirectness about the results, because these studies compare sutures, not compare sutures and meshes. So for me, I don't know. Probably in a patient, male aged patient, probably I will repair only the hernia, not the diastasis, in order to not increase the surgical procedure, because I am not sure that the hernia recurrences increase if we don't repair the diastasis. I don't know what the rest of the team
would it be different if it was umbilical versus epigastric? Does that make any difference?
Yeah, probably umbilicus hernia is different, because epigastrics in fact is in the middle of the diastasis, and maybe it's impossible to repair the epigastric hernia without repairing the diastasis. But regarding the umbilical hernia, I am not sure if we need to repair in cases of aged men diastasis. Another thing is a woman, a young woman after pregnancies, is another thing, because probably this woman needs an abdominoplasty and not only the repair of the hernia. But I am not sure if we should combine diastasis and with hernia in aged men.
So be careful with men. Women, perhaps the reasons are slightly different, or the etiology may be slightly different, and therefore there may be different outcomes. Any other comments from this question?
I think this must be a shared decision making between the patient and the doctor, what they're aiming for, what their real problem is.
It is interesting. You know, I had Barbara East with me as a fellow, and with their physiotherapy, operating on diastasis recti in women is virtually zero in the Czech Republic. Now, they have a slightly alternative or different view of physiotherapy. They do a very different physiotherapy, and they seem to deal with the problem through physiotherapy. So there must be a role, but I guess it's also partly down to society's views. For example, whiplash injury is very much a UK phenomenon. In other parts of the world, it doesn't exist. So I guess how people treat things and view things also has a cultural feeling. Hakan, next question.
Well, also, Andrew, it depends on the health system, because, for example, here in our country, diastasis recti is not considered a pathology in the codification. It's not included into the social security.
And it's not financed.
Does that work with other conditions? You know, for example, we have, if we look at the UK, for example, breast reduction surgery is judged in terms of the psychology, the degree of impairment, and similarly to diastasis recti would be. So a woman that clearly looked in advanced stages of pregnancy from her diastasis would be offered surgery, whereas someone you couldn't notice it in their clothes probably wouldn't. So is there any, but in Spain, is that just simply diastasis, no matter how bad it is not covered?
Not covered. In Spain, it's not covered.
Okay.
By the health system.
Yeah. Nadia, Denmark?
You can include it if the patient has an umbilical hernia that creates some pathology, and you add the other one.
Okay. So all of the diastasis in Spain has an umbilical hernia?
Yes.
Yeah, that's the easy way to
in the health system. In the health system, yes. In the private practice, it's different.
Maybe Andrew, the plastic surgeons here in Spain thinks in another way.
Yeah.
I don't know.
I think in the private practice, the plastic surgeon has a lot of work.
Okay.
So the next question: if diastasis recti needs repair, who should do it?
I guess, how can you mean, is that a general surgeon, a hernia surgeon, or a plastic surgeon, or combined? Is that what you mean?
The person who know how to do it, in my opinion.
And I think that let's say, we talked also a lot about aesthetics and the body image and that kind of stuff. And I think the combination of both, whether it's general or hernia surgeons, but in collaboration with the plastic surgeon, personally, I think is something that should be considered in a lot of female patients with the combination of repair of the diastasis and some kind of body image improvement or abdominoplasty or whatever. I think there the knowledge of both specialists is extremely important, at least in my opinion as well.
Yes.
Frederik, do you think the presence of an ugly cesarean section scar may influence the approach and whether plastic surgeons involved as well?
Of course, there you come back to the fact that what the patient feels is most important for her, in the way that if you consider an aesthetic correction despite the cesarean section incision, I think, of course, it's logical to combine this. If there is no wish from the patient to correct any aesthetic aspect of the diastasis, of course, it's different. And so again, the interaction and the wishes or the way the patient feels about her pathology is the most important part. But of course, it helps if you need abdominoplasty, you can correct the incision or the scar from the previous cesarean section.
But this has everything to do with the reimbursement system in different countries.
Yeah, I think that will influence, and I'm also conscious of, while the poll suggests that hernia surgeons should do most of them, the poll was targeted through the European Hernia Society Twitter feed, so it probably has a disproportionate number of hernia surgeons answering. So the fact that that may influence the plastic surgery and the general surgery outcomes. Next question, Hakan.
So in Twitter, when we post this guideline and some critics have been done, and we just shared this critics here, and you can read in the two critics. What would you say about this,
Yeah, they are that's opinions. I can say, I think that if you want to follow the great methodology, there is no way out of this. You have to say maybe considered and suggested when there is no evidence or very weak level of evidence. And I think that even though there is no evidence, guidelines are still important, because then we show at least that there is no evidence, and then we know where to focus the next research. And hopefully we also make surgeons think about what they are doing and why they are doing it. So I think guidelines are important, even though that the recommendations are weak, and in some cases there are no recommendations.
Any other comments from the panel? I think that's a very valid statement, Nadia, because it tells us what we now know, what we don't know. Yeah, Manuel.
Yes, I think that we should know what's the meaning of every guideline. Every guideline, they don't dictate any course of action, only help in the shared decision making, only help the clinician to speak with the patient and to comment with the patient because in my opinion, and above all in this type of pathology as diastasis recti is, we need to practice the shared decision making model, where we need to expose the patient the best case scenario, the worst case scenario, and finally, together with him or her, make a decision. And guidelines never dictate a course of action. Guidelines only help the clinicians in the process of shared decision-making model.
I think that's true. And knowing what we don't know is quite important, because I thought we knew more about diastasis recti till I read this, and I had more clear black and white ideas in my head when I was speaking to a patient. And I would have to say that I've now changed my tune, and I bring the uncertainty back into it, and trying to go back and pin down what the patients want. Manuel, several times you raised it, and it's not a specific question, but might be useful to discuss it now. And also from the guidelines, there was relatively, when there was outcome data, there was disappointing outcome data in a sense that back pain, for example, may have been the driver for repair, but that didn't seem to be improved. So are we labeling a lot of symptoms to diastasis recti, which aren't caused by diastasis recti, and that's why repairing it doesn't help the symptom? What does the panel think?
Yes, I agree with you, Andrew. It's difficult to address the rectus diastasis to back pain, pelvic pain, incontinence, or something like that, because there in the literature there is no evidence for that. And some patients tell after the repair is getting better and disappear back pain and something like that. But in the evidence and the consistency of the literature is absolutely nothing.
Well, here's a radical question then. Maybe it's because by the time you've got back pain, you have end organ damage, which is osteoarthritis, and we've missed the boat. Should we be screening for diastasis recti and operating them before they're symptomatic to stop symptoms happening in the future?
I don't think so.
So I don't have a good business argument there to set up a screening pathway of the populations and repair all these poor people.
No.
Who are 2 centimeters or more.
No.
I don't think so, indeed.
Oh, that's a pity. I was hoping to go for it. Very disappointed. My business model has been blown apart.
Absolutely ruined.
It is quite disappointing that the outcomes haven't been in terms of back pain, because we're saying that there's abdominal wall dysfunction, and restoring so-called core stability has not really helped.
It's very disappointing, as you say.
Yeah, I interrupted someone. Was that Manuel or Frederik?
Agneta?
Yeah, I was just going to say that depending on the reimbursement system, patients, they would sort of learn from others. So if they want an operation and they think they are ugly, they would put the symptoms being what is reimbursed. They would put those on the table, the ones that are a bit clever. And I think those are the ones that would get the operation for free in different systems.
That may be true. We know that patients do talk.
By us, it's very much such a discussion.
We've seen that on Facebook groups of how to get your hernia repaired in COVID and stuff, and the things that you have to say. So I think there's a lot of truth in that. But at the same time, it does make our job a little bit more difficult to unravel then as to why we're operating. And if we are doing it for cosmesis, then our general surgeons, the best people to do it when cosmesis is the end result.
So this is the last question. You state that more research is needed in this area. Which research questions will you set just now to have informed the next guideline update?
As we think in our group, a register is needed because to perform a randomized control trial between one arm of treatment or another one of surgical treatment is difficult. There is a low quantity of patients, and in the end, it's difficult to get conclusions about that. But if you get a lot number of patients, you get at the end sufficient information to make at least an approach of the answer of the question.
So a registry, any other studies?
Yeah, I think we need to start a bit before a registry, actually, because we need to know what to put into the registry. And therefore, I'm starting a collaboration right now with the plastic surgeons and the physiotherapists in my hospital, where we are doing a sort of a qualitative study, interviewing the patients on their symptoms, because we don't know which symptoms they have, actually. We don't know. And we want to find out which are the most important symptoms and which outcome measures should we use. And I think that is an important step before registries if we want to measure quality of our treatments. But of course, registries are also important. We're doing that at the same time, setting up the registry. But I think it's important to know what to put in it. What do we want to measure?
Are you aware of any good patient scales for abdominal cosmesis stroke function? So that's something we might need to, you're shaking your head, Nadia, so that's something we may need to develop as well. And I suppose linked to that is testing of abdominal wall function. I'm very much anti sit-ups because sit-ups give you a good six-pack to walk along the beach, but I'm not sure they do much good. We spend very little of our time dragging things with a rope over our back along the ground. So standing vertically is more important than bending and pulling something. So what do you think about our abdominal wall testing that we've done around both hernias and diastasis recti repair? Are we measuring the right thing?
Yeah, that's a very good question, Andrew. And our physiotherapists now are working on some kind of functional test, because we would like to see whether the patients are improving if they have surgery or not. And but it's difficult to find the right test without going into some kind of there are those machines where you can measure strength. But we want to do a test which can be done on the floor, or which is easy and which is reproducible. So we're working on that as well. Yeah, but it is difficult.
But still, if you have different tests, if they don't improve the quality for the patients to move around or whatever, what's the end point in doing a specific thing that you only do once to show the doctor? Because that should be would be an you should have a problem in daily life in one or the other way that should be improved. That's sort of, otherwise it's more like a cosmetic indication. So it's difficult to find something, and it's good, Nadia, that you are building up some sort of theory on what to test and what's important.
I suppose the question to that, is there any evidence in terms of sit-up? So we're doing it against a machine, that as your diastasis width increases, your ability to lift a particular heavy weight goes down. Do we have that data? So is there a clear association between rectus diastasis and reduced ability to do a sit-up?
No, there is no evidence in the literature.
But yet we all believe that because we're told that we have to restore the midline. The midline is some sacrosanct
not only
part
with
of abdominal wall function.
Not only with sit-ups. The most studied type of physiotherapy was hypopressive therapy, and it's completely different to sit-ups. It's used in most cases, in cases of incontinency, urinary incontinency or fecal incontinency. This type of physiotherapy, hypopressive, is very used in these cases. And patients with rectus diastasis that perform this kind of physiotherapy, they said that they improved.
Thanks very much, Pilar. I'm conscious we're getting near the end of our time. We have 5 minutes, so we have a bit of time just to chat in general. Manuel, Frederik, Agneta, Nadia, and Pilar, thanks obviously for taking part, but we're not finished yet. Any other comments that you would make, questions we should have asked you, other areas of research that we should be focusing on?
So actually, Andrew, Christian Jensen asked a question on Twitter that he makes a comprehension that no studies reporting recurrence rate of more than maximum 6%. Do you really believe this to be true long term? He asked. And he asked our comments on the low recurrence rate after the diastasis repair. You know,
most of the studies are at the minimum of 12 months. And the most long-term follow-up was 81 months with no recurrences, but only a small number of patients in this study. We don't know what happened with that because most of the studies are 12 months or 24 months after surgery, but we don't know what happened after that.
Personally, I think that that's an important point. I think most of those diastasis patients improve on the very short term, and they are happy initially with the result, and they can most of the time do a little bit better and do a little bit more at home or whatever. But over the long run, we don't have the data. And if, at least in my opinion, if you see the patients back years after, most of them indeed have an impression of recurrence, maybe not that bad again as that they were in the beginning, but it's certainly, in my point of view, not so frequently a permanent solution to operate on those.
Frederik, is that our problem? In other words, we give them the wrong post-operative advice? Do we tell them to take it easy, or do we tell them to work hard at their core? Should we be improving our post-operative advice? I
think that is important, but for me, it's something that you might see in other aspects of surgery as well. Once people improve, they forgot what they have to do to keep staying better. And so I think you have some disciplined people that say, indeed, okay, I need to do sports, I need to train myself, my belly, and so on. Probably those might be the ones that have a longer term better outcome, but we don't know, as was said many times. But I think in case a patient like in obesity, if they feel that they have the operation and don't need to do any diet anymore, they come into the wrong direction. So I think the same might be true here, and that you need to take care of your muscles and your abdominal wall in the long run.
The Americans had a great plan of a mission of abdominal wall health to improve the general population's abdominal wall. And we do see in Eastern and Western societies a lot of middle-aged men with rather pot bellies, and you wonder if they do any exercise. Have we, through our lifestyles and environment, set up the abdominal wall to fail now that we stand on 2 feet? I only ask easy questions, Pilar.
Your questions are getting better and better, Andrew.
I think I can't answer that question. It's impossible for me to know.
That's very hard.
Andrew, you can just go back to yourself if you get your fruit years or what happens
for the beer. That's what I blame.
Yeah, I thought so.
So you should go on all fours to get a beer from the refrigerator now.
I come home from
every time you get a beer, you go on all fours.
I don't usually go on all fours, but sometimes I do come home on all fours. Yeah. Hakan, thanks for setting this up. Nadia, Frederik, Agneta, Pilar, and Manuel, thanks for giving us your time this evening. Some interesting questions, some great replies. Thank you very much for all your hard work in producing the EHS guidelines. And don't relax too much. You'll be asked to revise them within the 3-year period. So keep reading the literature. Hakan, last word.
Thanks a lot.
Thank you for joining us. Good evening, all. Bye.
Bye-bye.
Bye.
Thank you. Bye.
Bye-bye.
Bye-bye.